Okay, so we'll do a case discussion now, which helps reinforce a lot of what we just talked about. Okay, so we're going to talk about a 32-year-old gentleman who comes into your clinic for the first time. He tells you that he has had HIV for 3 years. So what questions should you ask Mr. Smith?
How do you feel about that?
But it's really important. It's really important to ask that. Yeah.
You ask about if they know when they're infected and what their acquisition risk is, if they ever had a CD4, if they know what that is.
Mm-hmm.
If they've been on therapy.
Yeah, right. Just gauge what they know about HIV and their history of the infection. So, as was said, so when were you diagnosed? When do you think you were infected? How do you think you were infected? Do you know your CD4 count and viral load history? Have you ever taken any medicines? And have you ever had probing for opportunistic illnesses? Have you ever had any infections that were related to HIV and hospitalization history? Okay, so the patient tells you that he was diagnosed 8 years ago when he developed a flu-like syndrome and went to an urgent care center. He thinks he was infected as a result of heterosexual intercourse. He's never had anal intercourse and has never injected drugs. He's never been to see anyone before for his HIV, and he's never been treated with medications. He states he had some trouble initially accepting the diagnosis, but is now coming around to accepting it, and says that he wants to start ART. The only other thing he mentions is that he had chickenpox when he was in. So physical examination points of emphasis. We've talked about this. So these are things, again, to keep in mind, right? You want to do a comprehensive exam, but there are some areas of particular attention, I think, for HIV-infected patients. So a weight to assess for weight loss. A comprehensive skin exam can turn up important abnormalities. Lymph node examination, again, generalized might not be surprising, but focal should prompt concern. Oropharyngeal examination for a number of potential abnormalities, the anogenital exam, and then a neurologic examination, and particularly thinking about cranial nerves, a strength sensation, and a gait examination. Okay, so his physical examination is reassuring, and then you move on to talk about lab retained. So at the initial visit, what HIV-related laboratory tests should we get?
So we'll do a CD4 count, a viral load, a genotype. His CD4 count is low?
We don't know.
Okay. So I guess we can wait on the G6PD.
Okay. Yeah, I think that's right. So you want to get a CD4 count, viral load, a genotype, possibly G6PD testing if it seems appropriate, and then if you think you might use a Abacavir, better to get the B5701 testing early rather than later.
If someone really Mediterranean descent.
A lot of people don't.
Yeah.
Yeah.
Sure. So you can get. I mean, I at least. I don't get it on everyone. You know, I mean, especially I think. You know, I mean, it's appropriate and relevant if you're think you might be heading down a course of long-term Bactrim or dapsone use. But for someone who's newly coming to care with a CD4 count of 600, I don't really need a G6PD level for that person. So I think to some extent there's some, of the remnants of the earlier parts of the epidemic that are still at play, like the CMV screening and so on, that they're still recommended, but I'm not sure that they really changed clinical care very much. We used to spend a lot of time talking about the phenotype, which they're really not that relevant anymore. Phenotypes are interesting. They're really, I would say briefly, they're the province of heavily treatment experienced patients. And they're basically like getting an MIC, is I would say in a very short way of thinking about a phenotype. So a genotype tells you, what are the specific mutations that are present that may impact your selection of agents. But particularly for protease inhibitors, where you need to accumulate a lot of resistance mutations in order to be resistant to a protease inhibitor, right? As compared with something like efavirenz, right? You just need a single point mutation and you're resistant. For protease inhibitors, it's not like that. So when you have a combination of lots of protease inhibitor mutations, a phenotype might tell you which protease inhibitor is most active despite all of these mutations. So that's where an MIC kind of information might help. But otherwise, they're not very commonly done anymore. Okay, so other infection-related labs.
TB screening, syphilis, hepatitis.
Right, so toxo, TB, syphilis, hepatitis, right, that's essentially all of them here. So hepatitis B, at least a surface antigen and surface antibody, gonorrhea and chlamydia screening of the urine for everyone, and then potentially again rectum and pharynx, and then CMV, IgG is recommended, particularly I think for people with low CD4 counts. Okay, and then general labs, these are the sort of the routine panel, so CBC with differential, metabolic profile, urine, and then screening for diabetes and cholesterol. Okay, so the patient, so again, this is a 32-year-old man, infected for 8 years, never treated, comes back 2 weeks after his initial visit. He has a CD4 count of 300, viral load of 29,000, and no resistance mutations. He has a normal G6PD level, no evidence of any concurrent infection based upon the testing that you've done. He is immune to hepatitis B virus and has unremarkable blood cell counts, metabolic profile, and no evidence of diabetes or cholesterol. So he tells you he's had all of his childhood immunizations. He did get Tdap 15 years ago, and he also got meningococcal vaccination when he started college. So what vaccine should you administer to this gentleman? Mm-hmm. So TD, he's had Tdap, so that's a one-time thing, at least currently in the guidelines for adults. So a tetanus booster, a pneumococcal vaccine, and then, if seasonally appropriate, influenza vaccine. And then, so after he gets the pneumococcal conjugate vaccine, right? He's never had pneumococcal vaccine before, so that's the one that he should get. And when should he get the polysaccharide vaccine? Yeah, at least 8 weeks after he gets PCV13, and then again 5 years after that. So the patient is excited to start antiretroviral therapy. You prescribe medications at this repeat visit, and then make plans for a follow-up. So when should you get a repeat CD4 count?
3 months.
Yeah, so 3 to 6 months. This is unlikely to change quickly, so does not need to be obtained with his next laboratory profile. As compared with his next viral load, when should that be checked?
2 to 4 weeks.
Yeah, 2 to 4 weeks after, and then every 4 to 8 weeks until he's undetectable. And then once he's undetectable, when should he next have a viral load checked?
3 months.
So 3 to 4 months later. Very good. And then other labs that you should monitor, and how often? This is not necessarily infection-related labs.
So,
Glucose, lipids.
hemoglobin A1C.
Yeah. So that should be done within 1 to 3 months, which is important just to keep in mind. So after starting, you want to get those labs, and then annually if they're normal subsequently. And then CBC with diff and metabolic panel every 3 to 6 months, depending on you. Obviously, when you're getting other labs, you can just add those on if it's time for them. And if you're getting tenofovir, what other lab should you get?
Urine, protein, creatinine.
Yeah, urinalysis, screening for protein creatinine ratio if you see protein in the UA, and then possibly a phosphorus as well. Okay,
I'm just going to forward, and I'm just going to save it. So
that concludes this talk.